A very good afternoon to everyone. At the outset, I'd like to thank Dr. Gautam Kastagir, Dr. Trivedi, and Dr. Kedar Ganla for giving me this opportunity. So after that excellent talk by Dr. Shreyas, I'm going to talk about another controversial topic. So we'll talk about, does PGT-A really improve IVF outcome and what is its current perspective? So the reason why I chose this topic was because the utilization of add-ons in IVF is really increasing with the years. And we can see that in US, every 2-3 years, the utilization is almost doubling. And by now, perhaps it may have reached more than 50%. In the UK, it's remained a bit conservative at around under 2%. And that's because probably the HFEA has put a red light traffic signal on it, saying that there's not much of evidence to prove its efficacy. So I think you all may also be familiar with the class action suit that was launched against Monash IVF in Australia last year. And for those who don't, this was a 40-year-old woman who had one blastocyst. It was subjected to non-invasive PGT-A. It came out as aneuploid and it was not transferred. And the woman took the unit to court because she said that she was not informed that non-invasive PGT-A had false positives, and hence she was denied the opportunity of an embryo transfer. So I think at this juncture, it's very important that we actually understand what this technique can give us and what are its limitations. So when PGT-A first started in the 1993 or 1995, the initial hypothesis seemed quite logical. So we all know the limitations of morphological criteria to select our embryos. We know that embryo aneuploidy is the main reason for implantation failure, miscarriages, recurrent miscarriages, and prolonged time to pregnancy, especially with aging. So it seemed that selecting and transferring only the euploid embryos, which we derive whenever we do an IVF cycle, and transferring them would lead on to better clinical outcomes. So the purported benefits of PGT-A are to increase the implantation rate, to help us to select better embryos, especially when we are doing single embryo transfers, to assist in the birth of a single healthy child, to reduce multiple pregnancy rate, to reduce time to pregnancy, reduce miscarriage, and to supposedly make IVF cost effective. But has it really lived up to the hype that it has created? So if we look at the evolution of PGS, so it started off with PGS1, where we had cleavage stage biopsy and FISH up to a maximum of 12 chromosomes. Then went on to PGS2, where blastocyst biopsy with comprehensive chromosomal screening was done. And then was PGS3, where the term was changed to PGT-A. Here, blastocyst biopsy and only NGS was recommended as the screening technique. And a new term called mosaic embryos was introduced, and this was in 2016. And now we are at PGS4, where there is non-invasive PGT that is available. So now this systematic review by Mastenbrook in 2011 sounded the death knell for PGS1, where it was very clearly obvious that the technique did not help to improve outcomes for good prognosis patients, and it actually lowered live birth rates in the advanced maternal age group. So this was probably because of the mosaic nature of the day 3 embryos, the harm from the biopsy itself, and of course the limitations of FISH in order to screen the embryos. And the same findings have been confirmed by the recent Cochrane that was published just last year. So it's very obvious that we are not seeing any benefit in terms of live birth rate following, actually a reduction perhaps, following cleavage stage and FISH. So then came PGS2. So this is one systematic review published in 2015. So we can see here that the first one is 3 RCTs and the second column is observational studies, about 7 of them. So overall, they finally concluded that the clinical implantation rate and the sustained implantation rate were better in all groups. Now, if we look at this a little more closely, you can see that the RCTs have been done only in good prognosis patients. The outcome is implantation rate. Now, nobody uses implantation rate as an outcome measure. So this was a very clear representation of their data to show a benefit. And of course, these were the older platforms. That's the RACGH and the qPCR. So still not very convincing. So definitely PGT-A is a very controversial topic. There are proponents, there are opponents. So what we're going to talk about today is to have an unbiased discussion about whether it really increases success rates, does it reduce miscarriage rates. We're going to talk about the technology, how accurate are we in diagnosing aneuploidy, how representative is this biopsy of the ICM Are we discarding good embryos, and is the biopsy harming the embryo? And something about the biology of the pre-implantation embryo. So as far as the clinical thing is concerned, the problems with most of the published RCTs today is that, see, the original indications for PGT-A were older women, RIF, RPL, male factor, but now most of the RCTs have been done on good prognosis patients, young, and those who have more than 2 or 3 blastocysts available for biopsy. And also, if you look at the denominator, most of the ideal denominator is obviously per cycle started. So most of the analysis has to be intention to treat. But then we can see that most of the RCTs are per embryo transfer. So what happens to these other women who don't have any blastocysts formed, or who have only 1 blastocyst, or who have no euploid blastocyst, or no cryopreserved embryos? So this forms a sizable chunk of the patients that we see in daily practice. Now, I'm sure perhaps that maybe such a benefit that we are seeing in most of the studies perhaps could not be replicated if you were to include all these patients in the analysis and if you were to report your data based on per cycle started. So the Cochrane that was published last year was very clear in their selection, in their inclusion and exclusion criteria, and that's what makes the data interpretation useful to us. So they included only RCTs. They took patients with the traditional indications as well as good prognosis. They excluded studies which reported results on women reaching euploid embryo transfer only, where PGT-A was not performed on the entire cohort of embryos, and where multiple egg retrievals were allowed before arriving at 1 euploid embryo. And they looked at outcome measures, that is cumulative live birth rate per woman after 1 IVF cycle and live birth rate per woman after the first transfer. So the results show us that as far as cumulative live birth rate after 1 cycle, there are no studies on blastocyst. I think there is one that has just come up 2-3 days ago in NEGM. We'll just talk about that later. So polar body biopsy did not show any benefit. And in terms of live birth rate after 1 embryo transfer, so it was again seen that either polar body biopsy or blastocyst stage biopsy did not make any difference to the live birth rate, and also they did not see any difference in reduction in the miscarriage rate as well. So one of the studies that has been included in the Cochrane is the STAR trial. So here they included people from 25 to 40 years, and who had at least 2 blastocysts that were available for biopsy, and the ongoing pregnancy rate was the outcome measure. So it was seen here that if all the patients were included, the results were not statistically any different. So it was the same in terms of ongoing pregnancy rates and miscarriage rates, and so also in the younger population where there was no difference that was observed. And they said that in the patients with advanced maternal age, so they found that there was a statistical significance. But unfortunately, these results were per embryo transfer and not intention to treat. So if we were to analyze the STAR trial, again, it was only good prognosis patients, those who had more than 2 blastocysts available, those who had normal ovarian reserve. So though enrollment was at the start of stimulation, randomization was after confirmation that more than 2 blastocysts were available. So a good 167 patients were excluded from the analysis. So if you were to actually do a true intention to treat, then you have to include all these people, those where they had only no 2 embryos available, where there were no euploid embryos or thaw failure. Then the final number, denominator, comes to around 400 in each group. And when you do a corrected analysis, they found that there was no change in the outcome measures in all the groups. So PGT-A is not really favorably affecting IVF outcomes by increasing pregnancy rates or by reducing miscarriage rates. So the evidence is quite clear on this ground. And the latest RCT that has been published in NAGM 3-4 days ago, so that is on cumulative live birth rates, and that too in a good prognosis population, which have 3 embryos available for biopsy, and they found no difference in live birth rates, cumulative live birth rates in both the groups. So we also have some evidence from cohort studies on cumulative live birth rate, and they have also not found any difference in both the groups. So why are we not seeing dramatic improved outcomes? How good are we in diagnosing aneuploidy, and how accurate are these platforms? So the reason why PGS3 moved to NGS was because it was more sensitive. It had an ability to diagnose chromosomal mosaicism, even to the extent of less than 20% of aneuploid cells. And this, unfortunately, has resulted in a rise in diagnosis of embryos with uncertain clinical significance. So in PGS-C, we get euploid embryos, we get aneuploid embryos, and you get mosaic, that is the mixed embryos. In mosaic, you have low-grade and high-grade mosaic. You have diploid aneuploid mosaics, and ploidy mosaics. So traditionally, both aneuploid and mosaic embryos have been discarded and not preferred for transfer. So I think Dr. Keshav has spoken about this. So by discarding these mosaic embryos, what are we doing really? Another important thing is not all our labs give us reports about mosaicism. So in the US, it was seen that just 36% of clinics receive mosaicism data. I don't know about India. And the prevalence hence is extremely variable. It is like 4 to 33%. And if you look at the technology itself, it is said that the prevalence depends upon what threshold the lab used. As clinicians, we probably never ask these kind of questions, but whether they use a 20/80, 30/70, 40/50, so the prevalence varies. It also depends upon which tool, and of course, even NGS has various platforms, so it varies depending upon what platform we are using. So some people thought that, they really questioned this diagnosis of mosaic transfer, and they took the plunge and they decided, let's transfer these diploid aneuploid mosaics. And surprisingly, they found that live births were obtained, and today almost 200 live births have been reported following the transfer of mosaic embryos, with live birth rates somewhere between 30 to 48%. So this is a very elegant review where it was shown that mosaic embryos have a slightly lower implantation rate and a slightly higher miscarriage rate compared to the euploid. And low-grade mosaics tend to do better than high-grade. And this is not without caution. So recently there was a report of a baby born with mosaicism from a known mosaic transfer. The baby apparently looks okay, but nobody knows what its long-term outcome is going to be. So by discarding mosaic embryos, are we wasting them? Are we denying the patient the probability of having a healthy, normal live birth? So in turn, by reducing the number of embryos available, are we harming the patient by reducing the cumulative live birth rate, increasing the cost, and of course, a lot of confusion to us and the embryologists as to what to do. So definitely the question comes as to, are these embryos truly mosaic? So the only way to know this is to rebiopsy the embryo maybe 2 or 3 times, and also the ICM, and try to figure out what it really includes. So this was a very elegant analysis by Marine, where it was found that distribution of these abnormal cells is not uniform in the entire trophectoderm, and surprisingly they found that 1/3 of these mosaic embryos were actually fully aneuploid and another 1/3 were fully euploid. So it is for sure that a single biopsy is perhaps not representative of the entire embryo. So there are a lot of false positives. The numbers reported are anywhere between 20 to 50%, which is huge. So this incorrect classification is definitely giving us problems. And this increased incidence of false positivity is probably because of the use of intermediate copy numbers as the platform uses in order to diagnose mosaicism. Even if you give suboptimal number of cells in the biopsy, there are possibilities of false positives. And the whole technique of this whole genome amplification itself can cause some errors in terms of under or overrepresentation of the genome. The lab also can have problems. So Munne, in a very elegant study, found that the rate of aneuploidy varied so much from 40 to 80% between clinics. So definitely there can be something to do with the culture medium, the pH, the technique of the biopsy itself, and the expertise of the embryologist. So is biopsy harmful to the embryo? We always say, okay, trophectoderm biopsy is safe, but what is the evidence that we have? It's probably based on only 1 or 2 studies. Now, this was by Scott in 2013, which said that it was similar to euploid embryos, but these were good quality grade A blastocysts. But what about blastocysts which are poor quality, average? So definitely it may not be similar to good quality blastocysts. And also multiple biopsies, multiple cryopreservations have also been known to lower live birth rate. False negative errors, thankfully, are little on the lesser side at around less than 4%. What about the biology of the embryo? Can it self-correct? So there is some data from mice to say that in the ICM, the abnormal cells gradually deplete and live birth can be born, but then evidence from human studies are actually lacking. It is thought that the embryo self-collects about 5 to 8 days after fertilization. So probably biopsying the embryo on day 5 and trying to predict its future potential is probably early. So the best evidence is from non-selection studies. Now what are these? So you do the IVF, create the blastocyst, take the biopsy, but decide to transfer only based on morphological criteria. Once the patient becomes pregnant, then you analyze the biopsy and then correlate the biopsy results with the outcome of the pregnancy. There are only 2 studies that have been done so far. So the first one was by Scott. This was based on SNP microarray. So they found that of the 42% that were aneuploid, 4% actually there were healthy euploid births. So that's an error rate of around 4%. And the latest TEAK study, which was on blastocyst biopsy and NGS, so they found that none of the aneuploid embryos implanted, and the euploid embryos resulted in around 64% live births. So if it is a meiotic error, that is a uniform aneuploidy, I think PGS is quite good at detecting it. The only problem is with the mosaicism. So which patient group may benefit? So definitely PGS should not be offered to all, as we have seen from the evidence. And even in advanced maternal age, we saw the STAR trial where it was not useful. So see, if you have one euploid embryo that you're transferring, the implantation rate may be better, but the problem is getting there. So this is the group that is likely to have less number of embryos. So if we are denying the patient based on a false positive report, then obviously we are reducing their chances perhaps. And PGT pregnancies are not without harm. There is an increased risk of hypertensive disease compared to other IVF-ICSI pregnancies, which we must keep in mind. So last word about non-invasive PGT and where are we today. So how reliable is it compared to trophectoderm DNA? Amplification levels are good, 80 to 100%. Concordance also is reported somewhere between 85 to 90%. And day 6 media is supposed to be better than day 5. False positive rate is supposed to be lower than trophectodermal DNA, but of course these are with labs that have good experience with non-invasive PGT, and not all labs perhaps are able to replicate similar results. And does it have a role? Well, definitely everyone prefers non-invasive techniques. We all know how difficult it is to find an embryologist who does good biopsies. So if something non-invasive and if it is better may have a role. So it may also allow analysis of poor quality embryos that are not suitable for biopsy and those who are not willing for invasive testing. But of course, we don't know what is the exact source of this cell-free DNA. It can be from apoptotic cells, so it may not be representative of the ICM. Good embryos may have less cell-free DNA and failed amplification, and you need extended culture and its associated drawbacks. So to summarize, evidence has still been unable to demonstrate promised improvements in live birth rates and declines in miscarriage rates. It may have better implantation, perhaps lower multiple pregnancy or shortened time to pregnancy, but this is all perhaps in the good prognosis group. And then you will think, why does a good prognosis group need a selection criteria at all? They will anyway have good chance of getting pregnant. And we have all spoken about the drawbacks of PGT-A. So a lot of lacuna in existing literature. Future studies must randomize patients at cycle start and report cumulative live birth rate. We don't have much data about long-term neonatal and pediatric outcomes. Cost-effectiveness studies are still not there. And we need studies that are being done in poor prognosis patients and who are specifically looking also at miscarriage as an outcome measure. So to summarize, PGT-A can never increase cumulative live birth rate, can it? It can't. And the overall probability of having a child per egg retrieval cannot improve by screening the embryos. Actually, commercial ventures are marketing this technology, which is still quite early in its development, as something that's mature and established. It is, after all, just another diagnostic test. It's a screening test, so it can't be 100% accurate. It is not that much validated. Standardization is not uniform across labs. Most of the validation is done using cell lines, and cell lines have a lot of cells, and that does not compare with whatever 5 or 6 cells that we get in a trophectodermal biopsy. So the last 2 points are extremely important. Patients must be made fully aware of the risks and the benefits, and they must be provided an unbiased, free, and an informed consent before accepting to go ahead with the procedure. And it's, as of now, probably should still be considered to be a research tool, and it's probably unfair to charge patients for this add-on till more data is available. Thank you.